Welcome to Dr. Madhu's MedEd International, where we bring you clear, clinical, and concise concepts. Let's get into today's lesson. This video will provide an overview of dementia, including its causes, symptoms, diagnosis, and management. Dementia is a chronic organic mental disorder impacting the brain structures. Dementia is classified as a chronic organic mental disorder. It causes global impairment in intellectual functions and memory. Early stages often involve recent memory loss first. It also leads to the deterioration of personality. Furthermore, patients may experience a lack of personal care. Alzheimer's dementia accounts for about 70% of cases in the USA and is more common in women. Multi-infarct dementia is 10 to 15% and potentially more common in India. Lewy body dementia is approximately 4%. The etiology of dementia includes parenchymatous degenerative causes like Alzheimer's, Pick's, Parkinson's, and Huntington's diseases. Infectious causes include AIDS dementia, neurosyphilis, CJD, and viral encephalitis. Deficiency-related causes involve B12, leading to pernicious anemia, thiamine, and folate deficiencies. Toxic causes include alcohol, heavy metals, carbon monoxide, and various drugs. Metabolic or endocrine causes encompass hypothyroidism, hepatic or uremic encephalopathy, and Wilson's disease. Structural and traumatic causes are normal pressure hydrocephalus, subdural hematoma, and tumors. Vascular causes include multi-infarct and Binswanger's disease. Some causes of dementia are reversible, such as hypothyroidism. Another reversible cause is normal pressure hydrocephalus, or NPH. Vitamin B12 deficiency, which can cause pernicious anemia, is also a reversible cause. Other deficiencies that are reversible causes include thiamine, folic acid, and niacin deficiencies. The 5 domains of global impairment in clinical features are memory, recent memory loss first; intellect, impaired thinking right-pointing arrow difficulty in ADLs; judgment, poor judgment, reduced impulse control; emotion, emotional lability, irritability/apathy; thought, perseveration and possible delusions. A catastrophic reaction is a sudden outburst of rage or anxiety when a complex task exceeds their intellectual capacity. This slide uses the dementia mnemonic to quickly remember the key clinical features. D. Declining memory. Think first. Recent memories go missing before old ones. E. Emotional lability. Mood shifts quickly. Crying, irritability, or apathy. M. Motor signs. Gait change. Slowness. Poor coordination may appear later. E. Enduring. Greater than 6 months. Symptoms are chronic and progressive, not short-lasting. N. Normal consciousness. Patient is awake, and alert right-pointing arrow helps distinguish from delirium. T. Thinking impaired, poor attention, planning, judgment, and problem-solving. I. Incontinence bladder, plus or minus bowel, control problems in later stages. Aphasia. Difficulty in speech, naming, or understanding language. The following slides compare the bedside differentiation between cortical and subcortical dementia. Cortical dementia, such as Alzheimer's, affects the outer layer of the brain and presents with primary deficits like amnesia, aphasia, agnosia, and apraxia. Motor function is often normal in early stages. Subcortical dementia, like Parkinson's, affects inner deep structures. Primary deficits include slowed thinking and dysarthria. Motor functions are affected, with tremors, rigidity, chorea, and posture changes. Lewy body dementia is characterized by recurrent, detailed visual hallucinations. Diagnostic criteria, according to ICD-10, require evidence of decline in both memory and thinking. The functional impact is significant, with severity sufficient to impair personal activities of daily living. The patient has clear consciousness, and the symptoms occur without clouding, helping to distinguish this condition from delirium. The duration of symptoms is at least 6 months. Delirium versus dementia. Delirium is an acute medical emergency, whereas dementia is a chronic syndrome. The onset in delirium is acute, while in dementia it is insidious. The course of delirium is short, 1 week to 1 month, and reversible. Dementia has a protracted, progressive, and chronic course. In delirium, consciousness is clouded or disturbed. In dementia, consciousness is usually normal. The sleep-wake cycle in delirium is grossly disturbed, but in dementia it is usually normal. Attention is grossly disturbed in delirium and usually normal in dementia. Diurnal variation is marked with sundowning in delirium and is usually absent in dementia. In delirium, immediate retention is disturbed. In dementia, recent memory fails. Depression versus dementia versus normal aging. In normal aging, forgetfulness is common. In depression, the patient complains of memory loss, whereas in dementia, the patient rarely complains. In depression, the patient communicates distress and frequently answers, "I don't know." In dementia, the patient is unconcerned, emphasizes achievements, confabulates to cover gaps, and makes errors. In depression, there is a history of prior mood episodes, while in dementia, there is no history of mood episodes. In depression, there is marked variability on similar tests. In dementia, there is consistently poor performance. A diagnosis of dementia requires functional impairment, sufficient severity to interfere with social or occupational life. The next slides detail the investigation protocol for dementia. The basic screen must include CBC, urinalysis, glucose, electrolytes, renal and thyroid function tests, serum B12 and folate levels, and serology for syphilis. Functional investigations include neuropsychological tests, EEG, and a lumbar puncture if indicated. Structural and advanced tests include arterial PO2-PCO2, chest X-ray, ECG, and neuroimaging like CT or MRI to detect atrophy, infarcts, or tumors. The management strategy involves addressing immediate or reversible causes like hypothyroidism, NPH, and nutritional deficiencies. It also requires environmental control to ensure safety and reduce stress. Pharmacotherapy for dementia includes cognitive enhancers. The main groups are cholinesterase inhibitors and NMDA antagonists. Cholinesterase inhibitors are used in mild to moderate dementia. NMDA antagonists are used in moderate to severe dementia. The commonly used cholinesterase inhibitors are donepezil, 5 to 10 milligrams per day, rivastigmine, and galantamine. The commonly used NMDA antagonist is memantine, 5 to 20 milligrams per day. Mechanism: these agents slow the decline. They are not cures. Symptomatic management and warnings. Symptomatic management targets depression, psychosis, and anxiety. For anxiety, use low-dose, short-acting benzodiazepines, lorazepam. For depression, use SSRIs, sertraline, and citalopram with a safe cardiac profile. For psychosis, use low-dose haloperidol or risperidone. Contraindication: avoid antipsychotics in Lewy body dementia. Reason: neuroleptic sensitivity syndrome. Risk: severe life-threatening extrapyramidal side effects. Psychosocial and supportive care is crucial, including maintaining hygiene and nutritional support. The prognosis involves functional decline over time, with associated complications such as nutritional failure, infection risk, and physical injury from falls. Viva questions, rapid-fire review. What is a catastrophic reaction? Sudden rage/anxiety, when a task exceeds intellectual capacity. Pseudo-dementia versus dementia. Depressed patients complain. Demented patients confabulate/hide. Why avoid neuroleptics in Lewy body? Neuroleptic sensitivity syndrome causes severe extrapyramidal effects. Most common student mistake? Confusing delirium. Remember, dementia has clear consciousness. Thanks for watching. If you found this helpful, please subscribe, like, share, and comment for more clinically clear medical education.